Good evening, everyone, and thank you so much for joining me on this webinar where we'll cover high-yield hematology topics with a focus on blood smears and red blood cell morphology. My name is Moses. I'm an internal medicine resident interested in hematology and oncology, and I'm also a senior USMLE tutor with Med School Tutors. Just a brief word about who we are, what we're about. It's a company that has really built its reputation and what we love to do on helping students achieve success along the medical path. And that takes many forms. It takes the form of personalized online tutoring, all the way from pre-med to residency and the boards. It can take the form of advising through the various applications and hoops that we have to jump through. And myself and all of my colleagues really come from a range of steps along that path, anywhere from med students, residents, attendings who really have this fundamental love of teaching. But that's not why you're here. We're here to talk about hematology. And so without further ado, let's get into the topic. The agenda for today will be to cover the high-yield hematology topics that might show up on your examinations through blood smears, both because images can sometimes be intimidating for test takers, but also because they're so rich in the learning that can be had about the associated diseases, the clinical manifestations, as well as the basic science that you all need to know. At the end, I'll touch again on Med School Tutors. And throughout, please put your questions in the chat, fill out the form that just popped through the chat. And I really want to make this session as interactive as possible. So that means that I will be asking you to put your thoughts in the chat. Don't worry, everything that you type, I'm the only one that will see it. The other attendees will not be able to see it. But really, active learning is the name of the game here as you actively retrieve information that'll really help it to stick. All right, so I will also try to address any questions that come up in the chat. But if I don't get to your questions, there will be a live Q&A at the end. So if I don't get to it, please post the question again when we get to that part of the presentation. So I wanted to start off this session by taking a step back and giving you all some general tips about approaching any image-based part of the vignette that you might encounter. The first point that I want to make is that that image, whether it be radiology, whether it be pathology, whether it be a blood smear like we'll be covering today, all of those are just part of the larger vignette. And if you don't immediately recognize what's in front of you, don't fret. I know it's stressful, but you can still get to the right answer by using the typical reasoning processes that'll help you eliminate the incorrect answer choices and select the one best answer choice. The other thing to know is that the images are selected to really be prime examples of classical pathology. Again, these are tests that are testing medical students, not pathology residents, not hem-onc fellows. So they're going to give you really classic presentations of classic pathology. And throughout, what I will be hoping to do is to link these blood smears to disease vignettes to give you a sense of what is the illness script, what is the classic presentation for these diseases, as well as highlighting the basic science facts that are most likely to be tested, whether it's going all the way back to biochemistry or some of the subtle treatment decisions that might come up on step one and occasionally on step two, as well as the complex examinations. And again, to take a step back, hematology, I think, is frightening for some people. Lots of fancy terminology, lots of chemotherapies. It's a struggle to remember what the mechanisms of action are. But remember that at its core, hematology is very simple. It's the study of blood, and it's broken down into two arms. There's what has historically been called benign hematology. But as we know, for patients, some of these diseases are anything but benign. So some folks are now calling it classical hematology. And this is where you're really focusing in on disorders of cells and of the coagulation pathway. When it comes to disorders of cells, there's either too few of those cells, so the penias, the cytopenias, there's too many of the cells, the cytoses, or for some reason these cells don't work right. And the three major cell types or buckets that we look at are the red blood cells, the white blood cells, which, as many of you will know, there's many different subtypes of white blood cells and ways in which they can contribute to pathology, as well as disorders of platelets. And then, of course, the other arm of classical or benign hematology is disorders of coagulation. We won't be touching disorders of coagulation today, but just in the back of your mind, big picture, that's what we're talking about. And of course, we have oncology or the malignant hematology, which focuses on the leukemias and the lymphomas. And of course, from a training pathway, oncology is part of hematology in many circumstances and includes the solid malignancies. But as far as hematology, the study of the blood, big picture, this is where we're at. And just like a basic science curriculum of many med schools, it's important to look at the normal to then recognize the abnormal. So this, as all the slides and images in this presentation come from the American Society of Hematology Image Bank. This is an example of a normal peripheral smear. And it's important to have an organized approach when looking at a normal peripheral smear. Again, keeping this to the med student and test-taking level, generally speaking, you're looking for those three cell types. You're looking at the red blood cells. You're looking at their shape. You're looking at their number. You're looking at the central pallor, which should be somewhere between 30 and 45% of the diameter of the cell. All of these are clues to whether there's a pathologic process going on in the red blood cell lineage. Then you look at the white blood cells. We have a few examples here of what look like neutrophils. And again, you're looking at their morphology, their abundance, what are the different types of white blood cells that you're seeing in your smear that can give you clues to what might be going on in a particular patient. And I will say right now that it's very unlikely that you're going to be tested, at least zoomed out like this, on platelets, because platelets are tiny. They are all over the place, of course, but typically you're looking for their presence. If they're completely absent in thrombocytopenia, that can be a clue to something that's going on. But again, at this high level resolution, not much to say about the platelets. And of course, here I've color coded them. So the red arrow to a red blood cell, the white arrow to a white blood cell, and then that sort of grayish blue arrow pointing to a platelet. I could spend an hour going over all of the different white blood cells, the neutrophils, the basophils, the eosinophils, all of which are very beautiful and have their own distinct morphology and staining. We don't have time for that. We're going to dive into pathology right now. But just take a moment to look at the screen. This is what a normal peripheral blood smear looks like. So here's where we're going to get you all actively participating. So take a look at this image. And for those who immediately know what this is, please go ahead and put it in the chat. If I'm looking over to the side, it's because that's where I have the chat. I'm not ignoring you. Thank you so much for folks who are already chiming in. This is a zoomed in view, and I'm already getting a couple of answers. Beautiful. So again, this is zoomed in. If you follow my cursor, these sort of pinkish circles are red blood cells. Now notice that the red blood cells are stacked. I'm seeing a few folks saying that it looks like they're spherocytes, but that might be an artifact of the cells, some cells being stacked on top of each other. What folks are pointing out is that there's a lot of what look like white blood cells in this smear. And some of them look sort of with large nuclei. There's something abnormal about this morphology, but my eye's also drawn to this cell here that I'm highlighting that have a very strange morphology. And if I told you that this was an older patient, maybe having some B symptoms, folks in the chat have already been putting the right answer in. This is what a smudge cell, and I put in a zoomed in, smack dab in the middle there is the smudge cell. Thank you all so much for chiming in the chat. The reason they look like this is because the cells are very fragile. CLL, of course, chronic lymphocytic leukemia. So this is a malignant process. This typically affects older adults, The basic science things to know here is that markers that are associated with B cell lineages are positive in this, or lymphocytes are positive in this disease. And you can see that on your screen, CD20, CD23, CD5. And some of the clinical associations to keep in mind is that this is associated with autoimmune hemolytic anemias. And a feared complication is the so-called Richter's transformation, or the transformation to the large cell lymphoma, DLBCL, diffuse large B-cell lymphoma. So if you see this cell, it's because the cell was fragile when the pathologist or the lab tech was creating this slide. They moved that cover slip, and these fragile cells were crushed, forming the very characteristic smudge cells. Excellent work, everyone. And just a comment that CML is myelogenous, so it's of the myeloid lineage, not the lymphoid lineage. And of course, there you would be expecting more of the myeloid forms of cells, so basophils, right? More myeloid lineage. Okay, here is the next image. Take a moment to take a look at it. You'll notice that what we really have on the screen here are basically exclusively what look like red blood cells. And we also see a couple of platelets in this particular smear. And I want you all to focus in on this blood cell here that has a speckled pattern to it. Overlying it. I'm already seeing one correct answer. And so this is the point where you all should be go ahead and putting it in the chat. Beautiful. And folks are giving me the right answer, and as well as some of the underlying etiologies. You're absolutely right. This is basophilic stippling. So now that I've told you basophilic stippling, please put in the chat, what are some diseases that can lead to the basophilic stippling pattern? I'm seeing lead poisoning, beautiful, beautiful. Sideroblastic anemias, B6 deficiency. Lots of correct answers in the chat. So I'll just advance and zoom in. The top picture here is exactly what you all were saying, basophilic stippling, which is associated with many of the things that you all put in the chat, which is sideroblastic anemias, lead poisoning, myelodysplastic syndromes, that's what MDS stands for, as well as thalassemias. But really on the examination, I'm going to point you in the direction of lead poisoning and sideroblastic anemias. The reason that the red blood cells have that speckled pattern to them is because when you have a sideroblastic anemia, for instance, with lead poisoning, in which you have inhibition of ferrochelatase and ALAD, the ribosome components build up and they get stained. The correlate to this is the picture in the bottom. If I told you this is a bone marrow stain, what would be the name of this finding? What would be the name? Beautiful. Yeah, so that would be the ringed sideroblast, ringed sideroblasts in the bottom there. Beautiful. Here we have our next image. There's a couple of different abnormalities here that one could point to. And perhaps it would be useful if I also gave some context. So let's say that this is a young woman who, or even an older gentleman. The older gentleman perhaps notices darkening of his stools and some blood. The young woman, particularly heavy menstrual cycle. What might this be a clue to? And it just goes to show how important the clinical story is behind a vignette. Because in isolation, sure, some of you correctly pointed out that this cell right here looks a little funny. It might look like a helmet cell, right? And there's some funny morphologies here. The central pallor differs quite a bit. But what I'm zooming in on is that these cells are small. Here we have a white blood cell, and you see that the red cell is smaller even than the white blood cell. Some of these cells considerably smaller, so we have microcytes, and we also have a large degree of central pallor. The central pallor is expanded in this particular this particular smear, which leads us to the diagnosis of iron deficiency anemia. And again, the demographics are those who have chronic bleeding disorders, whether it's through the GI tract, whether it's through the GU tract. The presentation that you would read in that vignette would include fatigue, pallor. Great place to look is under the eyes, as well as glossitis, chiliosis, as well as pica. These folks sometimes have a propensity to be chewing on non-food substances, which is the definition of pica. Again, because their body is craving that iron. And of course, the labs are low iron, low ferritin, and high TIBC. Shout out to the chat who pointed out that the classic demographics here is exactly what I was saying. Cancer in older individuals, right? As well as any chronic bleeding disorder in young women. You're thinking of an older patient population. Excellent. Here's the next one, very classic image. And the chat is all over this, beautiful. So a lot of folks are saying target cells, that's exactly right. Now what I would love to see in the chat is, what are some diseases that would lead to this particular presentation? So we've identified target cells. I'm seeing thalassemia, that's absolutely correct. I'm seeing hemoglobin C disease. Yep, that's perfect. Any other diseases? Go ahead and put them in the chat. Another 10 seconds, and then we'll reveal the answer. Lots of correct answers in the chat. There's a broader differential here. The chat nailed the most commonly tested one, which is thalassemia. But remember that liver disease, as someone just put in the chat, and asplenia as well, you can see target cells as well as hemoglobin C disease, which someone put in the chat, really digging into those zebras, deep knowledge base there, which is wonderful. I will say that in thalassemia, you can have microcytosis. The MCV would be low, but the other parameters of iron metabolism, you wouldn't necessarily expect to be low unless these patients are also hemolyzing a ton and running through a lot of their iron stores. Just because hemoglobin C disease is something that folks don't think about often, I think of it as similar to sickle cell disease, except that the amino acid substitution is glutamic acid to lysine as opposed to valine. And the bottom picture shows some of the crystals that can be associated with the diagnosis of hemoglobin C disease. Wonderful. Moving on. Here we have another very classic image, which honestly, if I saw this on the test, and the question was diagnosis, I would immediately know what it was because it's so pathognomonic. Folks are immediately putting it into the chat. A good pickup from someone here asking about rouleau formation. And this is one of those situations where with rouleau formation, you're looking for other evidences of a monoclonal gammopathy, a plasma cell dyscrasia. So if you were seeing the crab constellation of findings, the hypercalcemia, the renal disease, the anemia, the bone lesions, and the bone pain, and you saw rouleau, beautiful. But there are false positives for rouleau, which is that sometimes it's the way that the slide was prepared. And if there's another finding on the blood smear that is screaming another diagnosis, I wouldn't get sidetracked. And I only say that because most folks in the chat are chiming in with the correct diagnosis here, which is, of course, hairy cells, which is pathognomonic for hairy cell leukemia. So I'm going to test you guys one step further because you're all so good. First of all, what is the treatment? And there's two right answers here. Go ahead and put it in the chat. If you know one, put one. If you know both, put both. And we'll give you all 10 or 15 seconds to put the right answer in. Yep, lots of folks are putting cladribine. The other right answer is pentostatin. As hematology and our knowledge of active agents in leukemias increase, of course, you could think about B-cell agents, targeting CD20, for instance. Lots of great answers here. I'm also seeing ATRA. Remember, ATRA is for 15-17 acute promyelocytic leukemia. So that's the association I would bring there. But absolutely, this is hairy cell leukemia. The classic association here is pancytopenia. So again, red blood cells are down, platelets are down, white cells are down, as well as splenomegaly. And the classic picture that I'm showing here zoomed in is because of the filamentous projections that give this disease its name. This is a leukemia of adults. You all were all over it in terms of the treatments, historically cladribine and pentostatin. Of course, if this was a HEMONC boards, you would have to know second and third line and the pivotal trials. But for you all, cladribine and pentostatin is what's in first aid. And another basic science point, this is trap positive. In the chat, someone's put, it traps the hairy monster. I love that. It's such a vivid image to remember hairy cell leukemia. Relatively rare, but if it shows on the exam, you don't want to miss it because it's easy points. The image points right towards the diagnosis. All righty. Moving on to our sixth image here. And actually, as you all are putting the major diagnosis or the major finding here in the chat, I'll just point out that in the lower right-hand corner, you see a beautiful cell, which is not related to the pathology, but you see that dark red staining, and that could be an eosinophil, the elusive eosinophil, along with the elusive basophil, some of the most beautiful cells in hematology. But you all are right on the money in terms of identifying the red blood cell as the site of pathology there. It looks all spiky and funky. This is an acanthocyte or a spur cell. Now, I put the image of this acanthocyte or the spur cell on top, and I'm contrasting it with a different finding, which is the echinocyte in the bottom. They look very similar. Let me give you the clue to tell them apart. Notice that the acanthocyte on top is very irregular. The spikes are different shapes, they're different sizes, whereas in the bottom, there is some variability, but the spikes tend to be of similar size. It's a more regular appearing process. I hope you guys can appreciate that. The top just looks a little bit less organized, whereas the bottom, it's a little bit more regular of a shape. Of course, the association here is with liver disease and a rare diagnosis of A-beta lipoproteinemia. The presentation you'll find there, typically in kids, because it's a disease of childhood, a germline disease, and it looks that way because the membranes are messed up, right? The basic science associations here are ApoB48, ApoB100, autosomal recessive, and you treat by giving them vitamin E and restricting long-chain fatty acids. And someone's pointing out in the chat that a lot of these neurological manifestations is because of fat malabsorption. They don't have vitamin E, and that it impedes the ability to properly maintain the neurons. Just to repeat, the top picture is the acanthocyte or the spur cell, and the bottom picture is the echinocyte, starts with the letter E, also known as the burr cell, but have no fear, we'll encounter that in the not too distant future again. Thanks for the questions. All right, I'm gonna give you all 5 seconds to absorb. There's a lot of text here. Interesting presentation of the A-beta lipoproteinemia. High yield associations, I know it's a blob of letters and numbers, but again, pretty classic presentation for acanthocytes. You'll notice that liver disease comes up a lot. Liver disease came up here in acanthocytes, it came up in target cells. So there is not one red blood cell morphology. It's not a one-to-one association, liver disease and red blood cells. There's a couple of different ways that it can present. Alrighty. Moving on to the next image. And again, if I don't get to your question, please keep it in mind, post it again at the end, and we'll get to it. And here again, the cell type that we're focusing on are the red blood cells. There's some pretty normal looking red blood cells in this image, but this cell right here, these cells in the top left corner, they're really all over the place. Folks are correctly pointing out helmet cells, schistocytes. Schistocytes is the finding here. I'll show an example of sickle cells a little bit later. They look a little different, a little bit thinner. So we can compare and contrast that a little bit later. But when I say the word schistocytes, go ahead and put in the chat, what are some of the diseases that you associate with schistocytes? Someone put in hemolytic uremic syndrome. That's absolutely right. That falls under the broader bucket of microangiopathic hemolytic anemias, which includes both HUS as well as TTP, as well as DIC. Beautiful. And folks are also pointing out that there's combos. You can see schistocytes in combination with, for instance, an eclampsia picture, maybe some liver dysfunction, and you end up with HELLP syndrome. That's absolutely right. What if you have a rheumatology sort of flavor of a presentation? They also have bad kidney disease. You might be considering something like sclerodermal renal crisis. And then I divide schistocytes in two big buckets. You can have the microangiopathic hemolytic anemias, which I just listed, right? That's your HUS, your TTP, your DIC. And it's micro because what's happening is these red blood cells are traveling through the bloodstream. They're encountering something, maybe a thrombus in the form of TTP, that's shearing that red blood cell as it's passing by that sharp obstruction. But you can also have macroangiopathic hemolytic anemia. And just as the name implies, macro, big. That's abnormal blood flow across a valve, for instance, a valve prosthesis, as someone in the chat was pointing out. Beautiful. And the last point I'm going to question you all on, TTP is a very classic cause of schistocytes. And I want you all to put in the chat, what is the protein that is abnormal in TTP? Beautiful, ADAMTS13. You all are too good. I can't get anything by you. So here's some of the diseases that you can see with schistocytes. I put an image there where it's front and center. We mentioned basically all of the differential diagnosis for schistocytes. Of course, the mechanical encompasses a broader set of things like prosthetic valves and bad hypertension. It looks this way, as I mentioned, because of the shearing of the red blood cells. Obviously, there's no one demographic that fits this, right? If it's hemolytic uremic syndrome, it might be a child that ate an undercooked burger and they got an EHECO157H7 infection. If it's TTP, it might be someone in their 20s or 30s or even older. In HELLP, it would be someone for whom eclampsia would be a risk factor. So again, highlighting the importance of the rest of the clinical information that's presented to you in the vignette. And just as a shout out, I mentioned at the top of the presentation that a lot of these images are from the American Society of Hematology Image Bank, which if you just Google that, you'll see basically hundreds of examples of beautiful peripheral smears. All right, friends, we're about halfway through. We're going to keep this going. This image should look familiar to you. It should look very familiar. What are we looking at here? And someone's a couple people right off the gate. This is great where we do a little bit of spaced learning. Previously, we saw acanthocytes, and just as people are saying, this is echinocytes, or the Burr cells. The associations being disorders of the major organs, the liver, as well as the kidneys. The one more basic sciencey biochemistry association is pyruvate kinase deficiency. And I'll reiterate the clue that I gave before. Note that the projections in the bottom, which is the echinocytes, are more evenly spaced than in acanthocytes, although the causes really do overlap. Awesome. All right. Here we have another blood smear. While you all are thinking, I'll plug the website that I mentioned again. That's the American Society of Hematology Image Bank. You put that in Google, you'll find a range of examples of each of these diseases. And folks in the chat are already popping off in terms of answers to what this might be. And just to call out, this peripheral smear is another example of, you can see all three lineages. So you see all the red blood cells. You can see some platelets along the bottom and right side of the image. And then smack dab in the middle, you see a cell that's a little bit bigger than the red blood cells. Big nucleus, white blood cell. Excellent. And as everyone has been pointing out, there's two main abnormalities. One of them is really common in this image. The other one's a bit of a subtle finding. The one that's more plentiful in this image are spherocytes. Spherocytes, absolutely. And folks have even been putting in some causes of spherocytes. Hereditary spherocytosis is one cause that can be tested on examinations. And I'll just point out here, this cell sort of looks like an elliptocyte, and there is a disease called hereditary elliptocytosis. I'll tell you that's not the diagnosis in this case, but there is a genetic disorder of red blood cells where the cells take on this elliptical shape. So that's absolutely something that you might call out. Perfect. So now let's take this a step further. Folks have mentioned hereditary spherocytosis as one possible cause of a smear like this. Give me another, can anybody think of another cause? Another cause of spherocytes. And I'm seeing one answer, which is hemolytic anemias. Yeah. And this is, you're sort of going down the rabbit hole with these things, because anemia is one big bucket. Then you have spherocytes, which has its own set of differentials. Below spherocytes, you have hemolytic anemias. Below hemolytic anemias, you have autoimmune hemolytic anemias. And within autoimmune hemolytic anemias, you can have both warm hemolytic anemias and cold hemolytic anemias, depending on which immunoglobulin class is implicated in the pathology. We'll go over details of that in the next slide. And someone mentioned G6PD. G6PD presents a little bit differently. We'll have a slide on that coming up. And someone else was putting in some of the genes that are mutated in hereditary spherocytosis. So last question before I go to the next slide, go ahead and put in the chat, what are some of the gene mutations that can be found in hereditary spherocytosis? I'm seeing spectrin, yep. Ankyrin, yep, band 3, you all are crushing it. Absolutely. So hemolytic anemias, these are the two that are most commonly tested. Of course, there's other diagnoses. The high yield associations, increased MCHC, which is one of the parameters that comes off of the CBC, the complete blood count, is associated with spherocytes and hereditary spherocytosis. You all beautifully mentioned the major proteins that are implicated in hereditary spherocytosis: ankyrin, spectrin, pallidin, band 3, protein 4.2. Spoiler alert, there's a bunch of others, but it's not relevant for you. And the last point is something that I teased a little bit when you all were answering the questions, which is that in autoimmune hemolytic anemia, it comes, broadly speaking, in two forms. You can have cold autoimmune hemolytic anemias, so named because on the extremities, like your ear tips, the tips of your fingers, your earlobe, where your core temperature is not quite as high, or the temperature there is not quite as high, that's where the disease can sort of flare. Is caused by IgM, and that itself has a differential. CLL, the very first smear that we saw in the beginning of this presentation, which, by the way, what was the finding that we saw in peripheral smear for CLL? Just some space learning here. CLL, smudge cells, perfect. That can lead to both a cold or a warm. Mycoplasma, which classically we think of as an atypical pneumonia, can lead to rash as well as a cold hemolytic anemia, as well as something common like EBV-driven mono can lead to a cold hemolytic anemia. And of course, the warm is IgG, and that's associated with some rheumatology sort of diseases like lupus. Keep in mind, hairy cells is for hairy cell leukemia. That's a malignant process Slightly different from CLL, which is chronic lymphocytic leukemia. All right, beautiful. Next, we go to this image, which some folks have already been putting it into the chat and other peripheral smears. Yes, the classic poker chips, the red blood cells stacked like poker chips. And you all are correctly pointing out that this is rouleau. These are rouleau formations. That's absolutely right, rouleau. And I see some folks putting in the chat the disease that's associated with rouleau that's tested on the step 1 and complex examinations. What disease might that be? It's a plasma cell dyscrasia. Folks are putting in the chat multiple myeloma. We already went over the CRAB criteria. Just to say that again, remember that you have lytic bone lesions, that's the B in CRAB, which can lead to the hypercalcemia. You can also have renal involvement. Classically, you know, the buzzword that's used is the Bence-Jones proteinuria. So that's why you test both a serum protein electrophoresis, the SPEP, but you also test the urine for protein. That's the UPEP, urine electrophoresis. Perfect. And of course, to make this diagnosis, you would then do a bone marrow biopsy. You want to see a certain percentage of the plasma cells. Let me give you a slightly different twist to this. What if I told you that this patient had vision issues or that they had evidence of hyperviscosity? What disease would I be referencing? Still a plasma cell dyscrasia, and you all are absolutely right. What I would be talking about there would be Waldenstrom's macroglobulinemia. And instead of IgG or IgA, which are common in multiple myeloma, I would be looking at IgM, the pentameric immunoglobulin. And because it's so big, it can lead to hyperviscosity syndromes, sometimes presenting with like chest pain because the hyperviscosity is not allowing perfusion at the heart. The tiny little blood vessels in the eye can lead to retinal issues and vision issues. So that's Waldenstrom's macroglobulinemia. So we went over all of this. The key association, the thing you need to know is the association with multiple myeloma. And in case understanding why this happens helps it stick in your memory, I'll just point out that all of these proteins, I mean, it's just an enormous amount of protein in the blood. And as we know, proteins are made of amino acids, which have positive and negative charges. And when you have so many of these proteins around with all of these charged side chains, that alters the electrostatic charges. It alters the way the red blood cell membranes are associating with one another. And for that reason, it can lead to the formation of these rouleaus, the so-called poker chips. Great work, everyone. And here is my favorite disease. Favorite not because it's a good disease, because it's actually a terrible disease, but favorite because it's a particular research interest of mine, and folks are already putting it in the chat. A couple of different diseases. So I think it's worthwhile to talk through this one a little bit. So first of all, remember that I said all hematology is essentially the coagulation cascade and then the different cell lines, red blood cells, white blood cells, platelets. And here what we're seeing is a lot of funny looking white blood cells. We see the red blood cells in the background, the way this image is sort of colored and contrasted. It's really highlighting the white blood cells. So we're in the white blood cells, and then we ask ourselves, do these look like mature, fully differentiated white blood cells? The answer is no. And how can I tell? What are the features of these white blood cells that are telling me that they're not mature? They're not well differentiated. And folks are already putting it in the chat. It's the very large nucleus relative to the amount of cytoplasm. It's the weird granulations, right? It's the overall size of the blast here. They're very large. So I'm thinking this is an immature leukemia, which means it's either acute myeloid leukemia or it's an acute lymphoid leukemia, AML or ALL. And folks have already pointed out that what we're seeing here in many of these cells are our rods, these long, thin, purple staining sort of rods in the cytoplasm. And it is for that reason that we can confidently say that this is an acute myeloid leukemia, because, as folks have been saying in the chat as well, these are made of myeloperoxidase crystals, essentially, right? Now, under normal circumstances, let's say that we didn't see a single hour rod, and it was just a large immature cell, and the presentation is consistent with leukemia. I wouldn't necessarily be able to tell whether it's a myeloid cell or a lymphoid cell. There might be other clues. For instance, ALL, very commonly, the age distribution more on the younger side. AML, almost always a disease of those age 60 or over. Median age is about 65. So the age can help you a lot. The hour rods is a dead giveaway, but let me also tell you that in real life, kids can get AML. There's an association with Down syndrome, for instance. And adults can get ALL. So these things aren't perfect. Just like everything in clinical medicine, it is a spectrum. And just to point out the hour rods, it's these thin rods here. In fact, these two cells here are chock full of them. All of these lines here are the hour rods. All of these, there might be a dozen hour rods on this cell right here, and maybe 5 to 10 on this one on the right. Awesome. What translocation would I be looking for if I saw hour rods? I'm thinking AML. What translocation am I looking for? Absolutely, 15, 17. And what genes do those correspond to? I'm seeing some great answers in the chat. Here is one of the pain points. One of the pain points of hematology. It's all of the translocations. It's all of the different funky sounding genes. So this one is actually PML RAR alpha. PML, retinoic acid receptor alpha. The PML is on chromosome 15, RAR alpha on 17. When you put them together, you have this classic translocation. And now, before I go to the next slide, one more question. What therapy is essentially curative for this disease? And the chat is going wild. Yes, it is retinoic acid. The technical name for it is all-trans retinoic acid, so we call it ATRA. And this is not something that will be tested on step 1 or a complex, but it was Lococo and colleagues in New England Journal a while back that defined all-trans retinoic acid with another agent called arsenic, wild, I know, arsenic, that leads to incredible cure rates and transform this from a basically universally lethal disease to one in which many folks can make a full and lasting recovery. So just to recap, acute promyelocytic leukemia, you've got a ton of hour rods. The translocation is 15-17. The treatment is all-trans retinoic acid. Everything below all-trans retinoic acid, that's me nerding out, not something you need to know. Arsenic and sometimes chemotherapy if it's very high-risk disease or targeting CD33. But you all are crushing it. Next, we're nearing the end here, friends. And here, this is something subtle. It's something subtle. This is something a trained pathologist would be looking for. The morphology of these neutrophils. The morphology. And I know folks have been waiting for this one. I've seen this answer a couple of times in the chat already as I'm glancing at you all. And you're absolutely right. These are hypersegmented. Now, folks often say hypersegmented. What does that actually mean? Well, remember that the normal neutrophil should have less than 6 lobes, right? You can also be hypo-segmented, not something you should worry about. But if you see more than 6, then you're thinking hypersegmented. And this one we see 1, 2, 3, 4, 5, 6, 7, maybe a little one here, 8. On this one, we see 1, 2, 3, 4, 5, 6, 7 on the one on the right. So we're definitely in the hypersegmented neutrophil. And folks have already been pointing out B12 and folate as the two big culprits. Honestly, if you're going to be tested, that's probably what it's going to be. Keep in mind, though, that there's a few other things, which we'll cover in a moment, that can give you hypersegmented neutrophils and that abnormal morphology. Here's one that people sometimes get tripped up about. There's some blood tests that can give you a clue as to which one it might be, folate or B12, right? B9 or B12. And that is methylmalonic acid and homocysteine. So if it's folate deficiency, will methylmalonic acid be elevated? Yes or no? Put it in the chat. What do y'all think? Lots of no's, right? With folate, it's no. With B12, it is. B12 has high homocysteine, high methylmalonic acid. And then with folate, you only have the high homocysteine, not the high methylmalonic acid. And the differential there is really nicely brought out because it's not just folate and B12. There's medications like phenytoin, like methotrexate, that can give you a similar morphology, as well as alcohol abuse. And that's another great point that someone's bringing up in the chat. B12 can have those neurologic manifestations, subacute combined degeneration, associated with B12 more so than with folate. Excellent work, folks. Excellent work. Just a few more. You know, you all are prescient because a lot of what folks have been putting in the chat for other peripheral smears is true for this one. So if I said someone from the Mediterranean, someone of African ancestry who has frequent, needs to come into the ED, unfortunately, dehydrated, in pain, we're thinking here, of course, of sickle cell anemia. And again, you know, folks were asking me earlier the difference between the helmet cells and the sickle cells. And I mentioned that the sickle cells were more elongated. Sometimes they have a little bit of a curve to them, hence sickle. Whereas the helmet cells, it truly looks more like something's got scooped out, truly evoking that helmet imagery. So absolutely, sickle cell disease. A few things that you might be tested on. In terms of the presentation, I think most folks would be able to pick this up just from the history of starting from a young age, perhaps an affected family member, the pain crises, and the autosplenectomy leading to infection with encapsulated organisms. From a basic science perspective, the sickle cell allele replaces the glutamic acid with valine. We know that hemoglobin F is protective. The therapy is hydroxyurea. But for all the heme nerds out there, there's actually been an explosion of other therapies that treat sickle cell, like voxelotor and crizanlizumab. But again, this will not show up on your examinations. And just to highlight the difference between the helmet cells and the bite cells, helmet cells often have, like when I think of a helmet, I'm thinking of like a medieval helmet, and they have like the little straps on the side. So often it'll have like two little blebs on the side that make me think of helmet cells, better known as schistocytes. Whereas bite cells, it's more like circular. It's sometimes a bit smaller, the bite, although not always. And as I've been saying, we'll see an example of something very similar to bite cells here in a moment. In fact, here it is. What are we looking at here, folks? Folks are putting both the finding and the diagnosis in the chat. So good. So on the left, the arrow is absolutely pointing to a bite cell. And that was on the left. On the right, we see Heinz bodies. And some of you all are so good in the chat. My goodness, you have the image on the left, the image on the right, you have the disease. As folks have already been putting in the chat. This is really classic for G6PD, right? And again, sometimes I want to reassure you, it can be stressful. Is this a bite cell? Is it a schistocyte? Great question. Often the clinical scenario will clue you in. So for instance, G6PD. What are some triggers for G6PD flare? Go ahead and put it in the chat. Yeah, so medications. I love that fava beans are being brought up because I've never seen a clinical case of it, but it shows up on every exam, so good to know. And then just illness in general, whether it's an infectious disease or otherwise. Perfect. So that's sort of the story that you would hear for G6PD deficiency. You look at the peripheral smear, bingo, you've got your diagnosis of G6PD. Now, let's say helmet cells, schistocytes. Those you see more with the, let's say it's testing microangiopathic hemolytic anemia. There you're seeing, oh, their platelets are also low. Or in DIC, they also have sepsis and their coags are messed up, you know, in terms of their fibrinogen, their PT and PTT. Or you get a really suggestive history in terms of an exposure, a potential exposure to an E. coli that would lead to hemolytic uremic syndrome. The vignette, the story will be hugely important in terms of helping you get to the right diagnosis. The image just helps you get across the finish line, giving you confidence that you've got the right diagnosis. And of course, you have the immune cells taking literal bites out of these cells, giving them that very classic appearance. All right. We have come to near the end. A shout out to a different disease, actually. I saw someone post a tennis racket. Tennis rackets under electron microscopy makes you think of Langerhans cell histiocytosis. But in this case, we're looking at a peripheral blood smear. And what we see here, folks have already pointed out dacrocytes, which as far as the steps and the complex exams, you should be thinking dacrocytes, myelofibrosis, the teardrop cells. Perfect. I'll also point out this is not something you would be tested on, but notice this red blood cell here that looks a little different. It doesn't have that central pallor. It looks a little bit bluish. This is a reticulocyte. So when people say, oh, the person is bleeding or they're having a ton of hemolysis, right? Let's check a reticulocyte count to see if their bone marrow is responding. That's what they're referring to here. And these other things look like platelets to me, by the way. So the major finding here is the dacrocytes. Here we have a reticulocyte, and we also see some relatively normal looking platelets that we're seeing better now because we're far more zoomed in than the first image that I showed. So again, these long cells here, these long are the dacrocytes, the teardrop cells. And basically any form of bone marrow infiltration, fibrosis, can lead to these dacrocytes. The way I think of it is these red blood cells are squeezing through, they're trying to escape the bone marrow. And so it's so fibrosed that they're not able to get out as easily as they might otherwise be able to. And that would be the dacrocyte showing up in your peripheral smear after they've, you know, navigated the escape route from the bone marrow. The MPN, myeloproliferative neoplasm range of diseases, which is primary myelofibrosis, the essential thermocytosis, and polycythemia vera, are really commonly tested JAK2 V617F, right? And as someone is pointing out in the chat, yes, you can get a sense of how well the bone marrow is responding to a need for increased production, for instance, in the setting of a bleed or in the setting of hemolysis or some other destructive process, is to look at reticulocyte counts. And you can actually correct the reticulocytes for your hematocrit to give you a corrected reticulocyte count. And that can help you decide if the bone marrow is responding appropriately, or if the bone marrow is not responding appropriately and there's something going on in that bone marrow that is not allowing it to produce the cells that your body needs. I'll be very honest with you. For 99.9% of the questions that show up on your examinations, you don't actually need to calculate a reticulocyte index. If you know the calculation, perfect, but it should be obvious from the vignette and from the value that you don't necessarily need to be calculating all of that. That's sort of an extra step that you can take. If you know it, great. All right. This is the bonus and the last image, leaving us about 5 minutes for questions. What are we looking at here? I'll tell you first off that these are red blood cells. These are red blood cells. And we have a weird looking inclusion, I would almost say. A weird looking inclusion. And what if I gave you the clue? What if I told you that it's called a Maltese cross? A Maltese cross. Folks are getting it right. I love it. It's babesia. So babesiosis, the treatment, might come up on your exam, is a atovaquone, and you add in azithromycin. It is transmitted by a tick, the same tick as Lyme disease, actually. And in the bottom, just to compare and contrast, because someone was putting in a question about malaria earlier, very similar. It's also a parasitic species. On the bottom, you see Plasmodium falciparum. And I apologize, the treatment for Plasmodium falciparum is not atovaquone plus azithromycin. That is the treatment for babesiosis. The treatment for plasmodial species writ large is sort of complicated. It depends on the resistance patterns of the particular country. You can try to treat the hypnozoites with primaquine. Folks are already putting that in the chat, lovely. But the treatment is sort of complicated. I'm not going to get into it now, but you can use a variety of different agents based on resistance patterns and the particular organism. Excellent. Okay, so I just wanted to wrap up by, first of all, congratulating all of you, future hematologists and colleagues of mine. I hope you're all excited to look at peripheral blood smears, just as excited as I am. And the take-home lessons here from a big picture perspective is, if the image helps you to clinch that diagnosis, like in hairy cell leukemia, there's basically nothing else it can be. It can help you tremendously. If you aren't sure what it is, have no fear. Use the rest of the vignette, the demographics, the presenting signs and symptoms, the physical exam, other lab tests, other imaging to help you narrow into a diagnosis. The vast majority of the time, even if you aren't 100% sure of your diagnosis, you can still get to the right answer and get those points on your exam. And then lastly, again, when you're looking at a peripheral smear, let's say you're completely lost, you have a little bit of time to think, be organized. Remember, you're looking either at red cells, at white blood cells, or at platelets. If it's a problem with red blood cells, look at the size and look at the morphology. 99% of the time, that'll give you the answer. If you're looking at the white blood cells and you're thinking of something malignant, is it an acute leukemia, immature blast, or is it a more differentiated cell that'll give you a clue for something like CML or CLL, right? And lastly, I just wanted to say that taking a step even back further, it can be super overwhelming to memorize all of these different things, the genes, the basic science associations. If you feel like it would benefit you to talk through what's your particular situation, the contact information for our team there is in the bottom, social media, phone number, the email. Please reach out. In a setting like this, I can't give you necessarily personalized advice, but you definitely deserve to have someone take your full situation into consideration. We offer tutoring and help not only with the content, but also with the strategy and also the schedule to help you achieve your best score. So really with that, I'm going to open it up to questions. With that, I'll stop sharing my screen. And we have a couple of moments here to look at questions. Again, if I didn't address a question of yours earlier in the chat, I tried to do it as much as possible throughout the chat. I apologize if I didn't get to it. Go ahead and put that question again in the chat, and I'll keep my eye on it for a few moments please don't be shy. That's what we're here for. I see one question right off the bat: how to differentiate myelofibrosis and aplastic anemia by clinical clues. Oh man, that is a phenomenal question. It is somewhat beyond the scope of what you are expected to do on the med school level exams. What I will say is aplastic anemia typically doesn't have dacrocytes. It doesn't have the sort of funny looking red blood cells. Why? Because in aplastic anemia, the bone marrow is taken over by fat. In other words, you're losing your hematopoietic stem cells. They're not producing, and the marrow is filled with fat. And you can think of fat as sort of being soft. That's the way I think about it. The red cells are able to escape without much difficulty. In terms of myelofibrosis, there you have a lot of, as the name implies, a lot of fibrosis, and you would be more likely to see the teardrop cells. So that's what I would say at this level. Obviously, there's molecular studies, there's more advanced pathology. None of that you should worry about at this step. Oh, another wonderful question that's a little bit beyond a peripheral smear, but it is a question about white blood cells. Differences between macrophages and dendritic cells, both are called Langerhans cells in the skin. So this is a point of a little bit of confusion. You know, macrophages in different tissues have different names. And that leads to a lot of confusion. Macrophages are predominantly phagocytic cells, right? The way it would be tested on step one predominantly is because macrophages are really critical for the formation of granulomas, right? Whereas dendritic cells, the way that they're tested, and again, I'm focusing here on the test-taking environment. Dendritic cells are antigen-presenting cells. Technically, macrophages are too, but dendritic cells are professional antigen-presenting cells. They take antigens, they go to the lymph node, they present it to the lymphocytes, activate the adaptive immune response. So that is generally the distinction between the two. All right, I'll keep it open for another 10, 15 seconds for any last questions. Again, I'm so grateful for your responses. Talking at the screen is so much more enjoyable when I have all of your enthusiastic participation. I'm not seeing any more questions. So with that, I'll just wish you all the best, whether you're starting out on your med school journey, whether your test is fast approaching, or whether you're here for a refresher on peripheral smears. Thank you so much for joining. We're all in this journey together. And I can't wait to either be colleagues with you in hematology or to consult you all as you become phenomenal physicians in whatever field you choose. Have a wonderful day. See ya.